All right. Well, welcome. We have such a joy and such a pleasure for you all today. We've introduced you to Dr. Tan in the context of essentials, essentials of diversity, but today you all get to hear from her talking about her area of expertise in DBT. So we'll just, without further ado, I'm just going to welcome Dr. Tan to talk about DBT. This is just, I've had her come last year and talk about this, and it was actually over Zoom also, which is so funny because it was like just before COVID hit. It was like literally the lecture right before like COVID hit, and we had to do Zoom, and so it was nice to have had one practice run of having a guest speaker doing something over Zoom, and we had everybody in class, and now this is like life. This is life for us now. So
Totally.
you
And this
totally
is
introduced us and got us got us prepped last spring. So this is great having you back again and on Zoom, but even a different format of us kind of recording it today. But I'm just, again, just so thankful for you to have you here to share your expertise with us. So thank you again, and I'll turn it over to Dr. Tan.
Thank you so much, Dr. Nelson. Please call me Erica. And yes, I super duper love geeking out about DBT, could do it for hours, and I want to be respectful of your time. So this is a bumper sticker version. I'm just going to talk a little bit about the reasons for why DBT came about, some of the research, and the biosocial model, which is foundational to DBT, because DBT is so much more than just the skills that people know about, right? Like in distress tolerance, emotion regulation, interpersonal effectiveness, like that's half of it. The other half of it is really conceptualizing our clients from the biosocial model so that we know what it is that we can do to help them to learn these skills. So DBT is not a suicide prevention protocol. It is a life worth living protocol. So we just happen to work with a lot of individuals who experience suicidal ideation, self-harming behaviors, or other target behaviors. And we call them target behaviors because we are targeting them for change. Recognizing that many of the people we work with have multiple experiences that create a ton of pain in their lives. So more than anything, I think having this conceptualization of the biosocial model actually helps us as practitioners in DBT to have a lot of empathy and compassion for people who are suffering greatly. So without ado, let me dive in. So these are the goals for today. It's just a bumper sticker view of DBT. Like what you get from this is just going to be, you know, kind of like when you go to Costco, it's like a sampling and you're like, that tastes real good. I'm going to grab a package of this. And my hope is that more people will become practitioners of DBT. And one of the reasons is that, you know, we have a huge, like, suicide for individuals between the ages of 15 to 34 is the 10th leading cause of death. I mean, sorry, did I get that right? Suicide is the 10th leading cause of death. Yeah, I think for that, no. Okay, I'm getting some things mixed up. But anyways, I know that it's really important.
It is, truth.
I'm starting to get things mixed up because I was just thinking about like, what? Wait, okay, we're going to hit some stats in a moment. See? Yeah. And this is me practicing one of those skills called radical acceptance. Like I'm just radically accepting that I totally fumbled on something and it's okay. We have stats, we can keep on learning. So we're going to talk about who benefits from DBT. We're going to learn about the biosocial model. And I'll talk a little bit about the modules. I mean, there are a ton of skills. If any of you have seen the skills book, it's like 400 pages of skills. So we're not going to be able to cover any of that today. That's like outside of the scope of this training. However, you know, if anyone's interested, you can always attend one of our trainings at Portland DBT Institute. We do a nutshell, we do a diving deep into skills. And then we've had groups who've come in for like a 5-day foundational. All right, so just a little bit. Marsha Linehan is the founder of DBT and she developed it at the University of Washington. What's super interesting is that she started out as a researcher. So she worked with chronically suicidal individuals, and initially she, you know, was trained in like some cognitive behavioral strategies, and noticed that when she was working with people that they would just get really frustrated with her. They're like, why are you trying to change me? And so she adopted a person-centered perspective with these same individuals who were experiencing chronic suicidality, and they felt really stuck. And they're like, why aren't you trying to help me? I'm in hell. And so this past year, she came out with her biography, which is called Living a Life, Building a Life Worth Living. And she talks about her own experiences with self-harm and suicidality and just that really crushing depression. And so, you know, I don't know if she met criteria for BPD, and I don't think that's the function of it, but the thing that was notable in reading that biography was that she was so acutely aware of how much pain she and others were in when she was hospitalized. And she made a vow actually to God that if she got out of the hospital and figured out how to get out of this hell, that was going to be her life goal, was to get people out of hell. And that's exactly what DBT is. It's a really profound treatment that is beneficial for so many individuals, not just those who are like chronically suicidal, diagnosed with BPD. It's super helpful for depression, binge eating. It's helpful with teens, individuals who tend to be really rigid in their thinking. There's this like spin-off of DBT called Radically Open DBT that was developed by Thomas Lynch. And so there's a lot of research right now that's being done with respect to like, what is it about DBT that is helpful? So a lot of individuals that we work with at Portland DBT do meet criteria for borderline personality disorder. You can see that there are many different painful problems that individuals experience, everything from like isolation, difficulty in interpersonal relationships, to like just problems of global living, right? Like adjustment with respect to unemployment is really high among people who have been diagnosed with BPD. Like many have other mental health concerns, like they may have had childhood trauma, you know, and just to note that a lot of the behaviors that many of our clients experience, it comes out of emotional dysregulation, and it is an attempt to regulate emotions. So the first thing that I just want to put out there is that if you're working with anybody who meets diagnostic criteria for BPD, please do not describe them as being manipulative, because the truth is that if you were being manipulated, you wouldn't know it.
Right.
If you, like, I have family members I work with who come in and they're like, yeah, so they didn't get what they wanted, so they started threatening suicide, they're being manipulative. And it's actually like, no, they're not trying to be manipulative. Like, this is their attempt to try and regulate their emotions. And sometimes it comes out of their emotional dysregulation. So we're going to talk about the biosocial model in a moment. But the thing to note is that from a DBT perspective, the crux of these behavioral problems is emotional dysregulation. That many people we work with have this biological vulnerability to emotional dysregulation. So in terms of prevalence rates of BPD, there was a lifetime, there was a huge community survey in 2008 that was done by SAMHSA, and they found that there was a lifetime prevalence of 5.9%, right? In comparison, schizophrenia is 0.4%, PTSD is 7.8%, bipolar is 1.4%. So it may be that a lot of people we work with, and you may experience this clinically outside of grad school, a lot of people who are diagnosed with bipolar may actually have a diagnosis of BPD. Like, I have had several clients who have both disorders, and it's not uncommon for people who have been previously diagnosed with bipolar disorder to be misdiagnosed with that.
Yeah. So
this slide I think is really helpful to see. And what it shows is that people who've been diagnosed with BPD are 45 times more likely to die by suicide compared to individuals who've been diagnosed with depression, bipolar disorder, opioid abuse, schizophrenia, anxiety, and PTSD.
Wow.
So I think this is why it's really important to have a lens of compassion, right? Like, individuals diagnosed with BPD just are suffering a lot. And you will hear me say people diagnosed with BPD instead of calling them borderlines.
Yeah.
Because I don't think it's helpful to characterize anybody by a diagnosis.
Absolutely.
So in working with people who've been diagnosed with BPD, there are multiple challenges. And sometimes it comes from what we call like the flavor of the week, right? You saw that slide with multiple problems, and it's not uncommon for individuals to come in saying like, I've got this problem at work, let's work on that. So you work on that. And then the next week they come in and it may be a relationship issue. And then the week after that, it could be that there's like some problematic eating, substance use, whatever it is. And it just feels like, oh my gosh, I'm playing whack-a-mole and we're not getting anywhere. Yeah. It is not uncommon for people diagnosed with BPD to not participate in treatment the way other individuals do. Like, you know, we have a lot of clients on OHP, and it is really hard sometimes to keep them in treatment. Like, there are just various life circumstances that come in that are so disruptive. Like, it could be transportation related. It may be that they're not feeling like doing therapy. It could be that there are problems with physical health, whatever it may be. Mm. It's also common for individuals diagnosed with BPD to become emotionally dysregulated in session. Like, I remember one time I had a client who was starting to, what I perceive, ramp up. And so I was trying to get her off of that train, and I was just clapping and trying to get her attention. And it was not the effective thing to do, because in like a split second, like she went from 0 to 100 and was standing over me, like yelling at me. It's just like, you're condescending, you're a terrible therapist. Why would you do that? And I was just like, all I was doing was like trying to get your attention.
Yeah.
You know, so when we talk about the diagnostic criteria for BPD, like just being easily angered and just having this really intense anger response is part of the diagnostic criteria. Mm. We see sometimes non-compliance and just really strong urges to quit treatment. A lot of individuals I work with just really struggle with persevering to problem solve. Like, there's a lot of mood dependent behavior, and that just makes it hard to, you know, use these skills consistently. And so we're constantly assessing and talking about commitment in treatment. So that is one of the strategies that's very different in DBT. Like, commitment's not just a switch that you flip on and suddenly the person is totally compliant with treatment. It's like every session we're constantly assessing. Life-threatening behaviors are also really problematic. And when we talk about the target and treatment hierarchy, it makes sense that life-threatening behaviors are a priority, because you can't help somebody to achieve a life that they want to live if they're dead.
Right.
So, and then the last challenge is that clinical progress can look really slow sometimes. Mm-hmm. And it may look like you're taking 2 steps backwards, 1 step back, or for some of our clients, it's like 1 step forwards and 2 steps back. You know, so it can be really discouraging for clinicians, which is why DBT is not done in an individual setting, right? It is done on a team, and it is most effective when we have a consultation team.
Yeah. I actually have a question about that and thought, because just like you said, part of this is like, it's done on a team because it is hard it can be really difficult on the clinician as an individual. Mm-hmm. And I wonder, I mean, again, I hear that the team part is part of how we support you as an individual clinician working with individuals with BPD. But mm-hmm. There's also those pulls in the moment too, in the room. And how do you, even just like what you were talking about with your patient that had that kind of rage response or like anger response, or sometimes I've heard, like I had a student talking about his patient who would just kind of be really condescending to him or tell him like he's a bad therapist or that he doesn't know what he's doing, or those kinds of things in the moment when they were giving, when he was saying things to her that she didn't want to hear. And what is it like, or what is that process like for you as the clinician to manage and hold those boundaries and the things like, what is it that you do in those moments when, and again, it's not the manipulation. We recognize that this is a response, right? For them, but what does it mean for you as a clinician to hold, and how do you, like, what's the goal for you in those moments?
You know, I think ultimately the goal is to help the client to get regulated.
Yeah.
And, you know, one of our therapist assumptions in DBT, just to summarize it, is that, you know, therapists are jerks. Like, we've probably done the thing that we're being accused of doing, right? Like, we may have said something that the client perceived and experienced as being invalidating. So if anything, it's like, okay, like, hey, let's just slow this down and talk about what's going on right here. Like, help me to understand what happened. Because I noticed that, you know, we were going along okay, and then I said something, and then now you're telling, like, you just expressed to me that I'm being condescending or I'm being a certain way. Like, what happened? Right? So it gives us actually the opportunity to do what we call behavioral chains, where we look at, you know, what was the prompting event that led to this target behavior of emotional dysregulation, like this dysregulated behavior. What were the links? What were the thoughts? What were the experiences? What were the sensations? What were the urges? Like, and it becomes grist for the mill. And I think that's what I love so much about DBT, because whatever happens in session, it's that microcosm experience, because it most likely has happened and will happen out in the environment. So let's deal with it. And let's talk about it in a non-judgmental way. And I think that's where, being a clinician in DBT, you have to have your own practice of mindfulness, because if I'm not mindful to my own defensiveness, I'm absolutely going to make things worse.
Right. That's good. Yeah.
Yeah. And so I think, you know, on the consultation team, which we'll talk about in a moment, one of the things that we do is we focus on us. It's not clinical case consultation. That's not what consultation team is. Consultation team is really therapy for the therapists. So when we're going through every week, because we meet weekly for an hour and a half, we have a form that we fill out, and it's all very therapist centered. Like, I need help with problem solving. I need help with assessment. I need help with building empathy for this client. I need help, and I don't know what it is that I need help with. Like, and so this is an opportunity for us to just highlight, like, hey, it could be that I'm the problem, because one of the primary assumptions in DBT is that the client can't fail in DBT, but DBT can fail the client, and the therapist can fail the client.
Right. Okay.
And this is a really important distinction from other therapies, where oftentimes the message given to our clients who've seen previous providers is like, you're not working hard enough.
Right. That's good.
So these nuances make DBT so much more profound than just like skills training.
Right.
I mean, the research shows that skills training is essential and beneficial for many people who are suffering from emotional dysregulation, because they need to know what to do, right, to regulate their emotions and to tolerate distress. And it's also these other things that happen in an individual therapy context, I think, that make it just both the integration of art and science.
Yeah, that's good. That's really, thank you.
Yeah, great questions. All right, so individuals diagnosed with BPD tend to be really high utilizers. We can see that they're 8 to 11% of outpatient clients. They comprise 14 to 20% of inpatient clients, and they can be up to 40% of the highest utilizers. Like, it is not uncommon, if you worked at Cascadia, if you worked at some of the other outpatient services in town, like, you might see clients coming back in, like, or I have a friend who used to work at Portland DBT Institute, and she is a social worker in the hospital system, and she works in the ER. Like, she frequently sees a lot of people who, prior to getting DBT treatment, like, come through because of suicidality. So this is just some other information that's really helpful, that among individuals who meet criteria for BPD, like 97% receive outpatient treatment from an average of 6.1 therapists. Like, when we talk about, when we're doing intakes with our clients and we ask them, you know, what was treatment like for you? Like, frequently they will tell us that they've been through multiple therapists. 72% receive inpatient treatment. And compared to those who've been diagnosed with major depressive disorder. Like you can see that individuals diagnosed with BPD are 4.7 times more likely to get individual, they're more likely to get group, they're more likely to get day treatment. Like they've got 5 times as many inpatient treatments. They're more likely to be treated with antipsychotics like mood stabilizers, antidepressants, like all the things. And this is actually super duper important to know, is that if you are meeting with somebody who meets diagnostic criteria for BPD, like they need to not be on benzodiazepines.
That's good.
We had a nurse practitioner who used to work with us who was very, very keen on getting many of our clients off of benzos, because benzos tend to decrease inhibition, which increases suicide risk.
Right. Which then highlights, right, the need for appropriate diagnosis, right? Because, and you talked about how individuals with BPD can be highly misdiagnosed and may be diagnosed with bipolar or other disorders or other diagnoses that a benzo would be really appropriate for. And so it's really important to have accurate and appropriate diagnosis so that they can get both the medication treatment, but also the therapeutic treatment, right? Because if we're not understanding that this is a BPD presentation, the way in which the therapist is also entering the room and what kinds of boundaries and what kinds of things, what the goal is in that space is going to look really different too.
Absolutely. Absolutely. And, you know, having a conceptualization from a biosocial perspective, which we're going to talk about in a bit, can be really helpful, because then you're able to identify which behaviors need to not be reinforced and which behaviors to reinforce.
Right, right.
So this is way back in the day when there was DSM-4 and there was Axis 1 and Axis 2, but this is initially who DBT was developed for, those who met multiple diagnostic criteria for disorders and were severe in their symptomology and difficult to treat. And that chronic suicidality was definitely key. So DBT, from an outsider's perspective, it may look like it's really rigid. But the thing that is notable is that it's a principle-driven treatment that has many different protocols, right? So what we mean by that is that we have, for example, the 24-hour rule, that if somebody engages in life-threatening behavior as a means of coping with distress, that the requirement is that they not contact their therapist for 24 hours. So if somebody self-harms, they're not going to be like, hey, I self-harmed, when they call their therapist for skills coaching. It's that they have to abstain from contact because we don't want to reinforce that. Another protocol is what we call the 4-miss rule. That if somebody misses 4 sessions of individual therapy in a row or group therapy in a row, then they have to wait until they would have graduated from treatment before they can start up again. And that's not rejection of the client. Like, clients are fully informed, and during those 4 weeks, we are doing our best to reach clients, to pine. Like at this moment in time, I've got a client in my group who missed on Monday. So if he misses again, like I contacted him on Friday. If he misses again on Monday, like I'm going to be calling him again, like just trying to help him to problem solve to get him back in the group. So we're not just like sitting back and like, all right, so they've got 3 more misses. Let's just wait, you know?
Right.
But we're doing our best to help our clients to problem solve things. And sometimes they're just life circumstances that get in the way that they need to problem solve first before they make a commitment to this treatment. Because it is really time intensive. So DBT is a flexible, personalized, and idiographic approach. Flexible in the sense that, you know, each clinician is who they are, and you show up as who you are as a person when you're a DBT therapist. And that's one of the reasons why I love it so much, is that I don't have to be like this blank slate. We talk about being radically genuine in the sense that if a client asks me a question, I'm going to answer the question. I'm not going to be like, well, tell me why you're asking that question. And if I don't want to answer it, I'll just say, I don't feel comfortable answering that question.
Right.
Like I work with a lot of parents of teenagers, and I frequently get this question, do you have kids? No, I don't have kids. You're the expert on your teen. I'm an expert in behavior.
Right.
That's my job. Right. And I think the other thing that I love about it is that, you know, I can treat somebody who's been diagnosed with major depression and borderline personality disorder and have a second client with the exact same diagnosis. And the things that we do are going to be totally different. It's going to be personalized to each of them. And my goal is to help them to figure out how to have a life worth living. One person may want to have a life worth living that's defined by career goals. Another person may want to have a life worth living that's defined by relationship goals. So we work off of the client's wisdom, like their ultimate wisdom. What are their life worth living goals? Because that's what we want to head towards. It's not what I want for the client. It's what they want.
Yeah. I really like that language around life worth living. In ACT, they talk about values, but I feel like the language around a life worth living is so much more nuanced and encapsulates. I don't know. Again, it's talking about your whole being, the life, and especially for individuals who tend to have life-threatening behaviors, or that they go towards that more hopeless side more quickly, right? Is how do we move away from life is no longer worth living towards understanding and having a fullness of what is a life worth living for you, right? Not what it is for this person or that person over there, but for you, what is a life worth living? So that when we start to get to that place, we can kind of refocus our attention here to the things that are worth living for.
Absolutely. Like I'll give you a quick example. Several years ago, I was working with a mother doing some parent coaching, and she had a teen who was being seen by another clinician, and they had a really conflicted relationship. And this teen had been adopted later in life by the mother I was working with, and her husband, and they're both educators. And so they were trying to do their best to give this kid every opportunity. They were sending her to like a special program at a really expensive private school, and kiddo just did not do schoolwork, was skipping school, was doing everything she could, like a lot of school avoidance. And so I was talking with mom, and I was asking her, like, so what's your kid's life worth living goal? And she said, well, she wants to go on Broadway. I was like, okay, well, let's just do a behavioral can we just talk about this? And I had a whiteboard in my office, and this is pre-COVID days. And so I just asked her, all right, so what are the different ways she can get to Broadway? Does she have to graduate with a high school diploma, go to college to get to Broadway? I mean, that could be one way she does it. It could be that she graduates high school, goes to a junior college, transfers to a four-year college, goes to Broadway. It could be that she like moves to New York when she turns 18, works at a restaurant, somehow auditions, gets to Broadway. It could be that she gets her GED, maybe does some college, maybe doesn't, moves to New York, goes to Broadway. So and so we just mapped out like 5 or 6 different routes. And I just said to the mom, like, look, I don't know that it's beneficial for you to keep on pushing this school thing, because it doesn't seem to be your daughter's life worth living goal. Her life worth living goal is to get to Broadway. Sorry, my dog just came in. Hi, Daisy. Okay, hi. I'm glad that you had a good walk. Okay, go. Oh, okay. Do y'all want to see her?
Yes,
Daisy,
please.
Daisy.
Hi, Daisy. And now Kanye is like, oh, I hear somebody.
Sorry about that. I'm just realizing that we're making all these allowances in like Zoom time, like things that we wouldn't ordinarily do.
True. It's Zoom. We're good.
Yeah, that's totally fine.
Yep.
But anyhow, all that to say that when this mom came to this realization that she needed to be supportive of her daughter's goals, she just let go of the rope and said to the kid, hey, if you want to drop out and get your GED, that's cool. Or you could do it in your own time. Like, but here's the condition. If you're not in school, you got to get a part-time job. Like, we need you to be doing something. So kiddo dropped out of school, got her GED, got a job, and then started classes at community college.
Yeah.
So the exact thing that she was wanting, like the kiddo was able to do when she didn't feel like she had to do the thing.
Right. And she wasn't, there wasn't these, it had to look this way, right? From the mom's or the parents' perspective, it has to look like this. Once they kind of relinquished that control and allowed her to kind of pursue the way in which her life worth living looked, then it was able to flourish in a way that was also something that her parents wanted for her, but in the way that worked best for her.
Exactly.
Yeah.
Exactly. So that's why it's a flexible, personalized, idiographic approach.
Yeah, that's great.
So if we talk about who benefits from DBT, you know, we've mentioned before, like those who are chronically suicidal, those who are multi-diagnosed, difficult to treat, individuals who have a diagnosis of borderline personality disorder and substance use. And that's actually really important because, like, for a lot of individuals we work with, you know, substance use is something that just helps them to get away from the intensity of their pain, and it also maintains a lot of their problems. NSSI are non-suicidal self-injurious behaviors. So this is self-harm with the function of regulating emotions as opposed to wanting to die. Bulimia and binge eating, depression in the elderly, adolescents. So there are multiple research studies that show that DBT is helpful for these individuals. Bye, Daisy. So in terms of outcomes, we see that there's a reduction of, like, you know, self-harming behaviors, suicidal behaviors, depression, hopelessness, anger, eating disorder behaviors, like the reactivity from PTSD, substance dependence, impulsivity also decreases significantly. So you can see that there are a lot of life-threatening behaviors that come along with that, or high-risk behaviors, like sexually, like STD, HIV, high-risk behaviors also decrease. So in general, when people feel like they have the skills to be able to tolerate their emotions, their general and social adjustment increases, they experience more positive self-esteem, and they stay in treatment longer. Like, people will stay in treatment if they feel like it's working.
Right.
So just another quick story. I have a client who, she's been in treatment for a while, and she was a transfer client to me. When she started treatment with this other clinician, she was like self-harming in really vulnerable places. Like, we're talking like self-harming on her genitals. She was like, you know, using like not Coca-Cola, but like cocaine, marijuana, alcohol frequently. She had just lost her job. She was on disability and stuff like that. And fast forward to where she is today. She's been 5 years sober. Moved out of her mom's house last year, is currently on disability. However, she is working a part-time job consistently. And we've been working on getting her to apply for a full-time position that pays a living wage so that she can get off disability. Right. And so the thing that was notable was that before she got her part-time job, she isolated a lot because she didn't want people to ask her, like, hey, what do you do? Because that's a very common question. Like, what do you do? Like, I'm a psychologist. I blah, blah, blah. I do this, I do that. And her response was like, I don't know how to answer that. And it created a ton of pain and anxiety for her because she was like, I watch the news for 8 hours a day and I live at my mom's house.
Yeah.
And now she can say, yeah, I work.
Yeah.
I do blah, blah, blah support at this company.
Right. That's awesome. That's such a huge shift.
Yeah, it's super cool. So let's talk about the biosocial model and the biosocial theory, because this is like the meat and potatoes. If you're vegan, it would be like the vegan meat and potatoes.
The seitan and cauliflower mash.
Right. There you go. There you go. Equally yummy.
Yeah.
So, you know, according to the DSM-5, Diagnostic criteria for BPD includes a pervasive pattern of instability of interpersonal relationships, self-image, affect, and marked impulsivity beginning in early adulthood and present in a variety of contexts, as indicated by 5 or more of the following criteria, which we're going to talk about. So just to note, like, even though DSM-5 permits the diagnosis of BPD in teens, we generally do not, because they haven't lived long enough to demonstrate this pervasive pattern of instability in all these things. Like, this is also adolescence.
Right. So teenagers, right?
Oh my gosh. Like, before you and I started this call, my wife and I were going through some pictures. A friend of ours had sent a picture of herself, like, from several years ago. We were just like sharing pictures. I was sharing a picture from like 2004. And I was just like, oh my gosh, I'm so glad I didn't peak then.
Right. Oh, yes.
Yeah. Talk about, like, even then there was this instability of like self-image.
Oh, yes.
Yeah.
I thought I was a skater, but I wasn't. I'm like skateboarder, but I was really a poser because I couldn't skateboard. But I was wearing the, like, the cargo shorts and would go to the skate park with my skateboard and just sit there and pretend. So yeah, the self-image thing. I relate.
Oh my gosh. Seriously. I had minivan mom hair.
I love it. I love
it. Someday I'll show you the picture. It's like a little embarrassing.
Yeah. I love it.
All right. So these are the diagnostic criteria. There are 9 of them. And so in order to meet diagnostic criteria for BPD, you need 5 of these. So frantic efforts to avoid real or imagined abandonment. Mm-hmm. Just a quick story. I had a client who thought that her boyfriend was cheating on her. So she pinged his phone, figured out, I don't know how she did this, but somehow she figured out which hotel he was staying in, and he was staying with the girl he was cheating on. So it was confirmed. And so she's driving around the parking lot, like screaming his name, just causing this commotion. Police get called. At one point, they're like screaming at each other, like he's on the balcony and she's in the parking lot. And police are trying to get her to go away. And throughout this experience, she is just like saying to the police repeatedly, like, can't I just go over and like get a hug from him to know that things are okay? And one of the things that cued her to like the fact that he may be cheating was that she had sent him a text message asking him, like, are you cheating on me? Didn't get a response. So within the space of 20 minutes prior to driving to that hotel, she had texted him and called him 100 times each. Yeah. I was like, I don't even know how, like, you can text that fast or make that many calls, but like that's what we refer to as like these really frantic efforts to avoid real or imagined abandonment. A pattern of intense and unstable interpersonal relationships. Like, we see this with many of our clients. It's like, it may be that it's not just with romantic relationships, it can also be with friendships. Like, I see this a lot with many of my clients, that they may be best buddies with, or best friends with somebody like for a really short period of time. And then like suddenly, like one week, that person is no longer in their life. And that person is like the worst person ever. And then somebody new is like their best friend. Or we see that in romantic relationships too. Just the up, down, up, down, up, down. The identity disturbance or problems with sense of self. It's not uncommon for a lot of people I work with who've been diagnosed with BPD to not know who they are and to not know what they like or what their preferences are. Like, there's just a lot of uncertainty around that. Impulsivity that's potentially self-damaging. I had this one teen I worked with who, if she was ever up past 11 o'clock, like, guarantee at some point, like in the next day, she'd be self-harming, or maybe that night. Like, I just called it the witching hour. And so I remember she came in one day, and I had asked her, like, as part of our treatment, we asked about like life-threatening behaviors. And she's like, yeah, I guess. And she shows me her arm, and she had scraped her arm with like a needle because she like really, really, really likes the look of gore. And she had embedded costume jewels in it, thinking that'd be really cool to have like shiny, glittery, like wounds on her arm.
Interesting.
Yeah. And so we talked about how like she just couldn't sleep. And then instead of trying to use some of the sleep protocols that we were working on, sleep hygiene protocols, like she just started wandering around her house, came across a needle, was just like, oh, why don't I do this? This seems like a good idea. And like just started carving herself up.
Mm, mm, mm.
So what's interesting about that individual is that it was not done to regulate an emotion. Like she was actually in a regulated state. So it wouldn't count as recurrent non-suicidal self-injurious behavior per se.
Mm. Interesting.
Like many other individuals I work with will try to regulate emotions using suicidal or, self-harm in that particular fashion. The affective instability, it's that up and down, and oftentimes not just one emotion, but multiple emotions.
Yeah. Yeah.
Chronic feelings of emptiness. I hear this a lot, especially from my adult clients who say that they notice these feelings of emptiness. They just notice like there's nothing. It's not just loneliness, but like this really deep-seated emptiness. Like they don't know who they are. And so it ties back to that sense of self. Inappropriate, intense, or uncontrollable anger. I told a story earlier about like trying to get a client's attention and just this really intense lashback.
Yeah.
And last thing is what we call these transient stress-related paranoid ideation or severe dissociative symptoms. So many clients I work with have had really intense trauma at some point in their lives, maybe childhood, maybe, in adolescence, adulthood, whatever it is. And so the dissociation is like their mind's way of kind of just turning off so that they can cope with really intense emotions. And then over the course of time, what had been a respondent behavior then becomes an operant behavior in the sense that, it's done and by operant, we're not saying that it's intentional, right? Like some clients don't do it intentionally. However, it is a way for them to avoid experiencing really unpleasant emotions that they may not be aware of at that moment in time. Yeah. So Marsha Linehan, in her brilliance, took those 9 diagnostic criteria and summarized it into these 5 areas. So that emotional dysregulation, that affective instability, problems with managing anger. So when we talk about this biological difference in emotion regulation that many of our clients have, it's characterized by heightened sensitivity to emotions, heightened reactivity that leads to impulsivity, and a slow return to baseline. So what you can imagine is this. I'm going to do, all right, this is our first time trying that screen share, Amber.
There you go.
Oh, I'm touching my computer screen, thinking it's my iPad.
It's the iPad. Oh, I've done that. I have done that.
Oh my gosh. All right, let me do it this way. All right, can y'all see that?
Good. Yep.
Cool. Okay, so when we talk about this, imagine time over intensity. So for somebody who has been diagnosed with BPD or who just has this biological vulnerability to emotion dysregulation, if they had a twin, let's say they had a twin who was in the typical range, so to speak, with respect to emotion regulation, it may be that both of them wake up and they're late. So one twin wakes up, the one who experiences like what is typical, so to speak, they may wake up with this anxiety, but because their body just naturally regulates and calms down within 5 minutes, they're like, okay, this is the thing that I got to do. Like, I'm late to my Zoom call. Like, let me just throw on like a shirt, a sweatshirt, whatever it is, and jump on the call. So the person who tends to have this emotional vulnerability may wake up and be at a higher level of intensity of emotion just naturally, right? It's not uncommon for a lot of my clients to say that they don't even know why they're experiencing emotional vulnerability. They wake up and they're just feeling off. So, the client feels off. and then realizes like, oh my gosh, I'm late. But then because they have what we call a slower return to baseline, it takes them a little bit longer before they come back down. Right. And it may be that before they even come back down, like a 7-second event happens, which is like they have a test that morning. So, you know, sibling experiences some anxiety and fear, but their body calms down, whereas the second individual, it just shoots them back up again. And they're not able to regulate themselves. And then maybe there's a third event that happens, you know, Zoom crashes. And then, but this sibling up here is already like experiencing such intense emotion that they have trouble just coming back down. And so what we notice is that when our clients are here and they're interacting with somebody who's in the typical range, and we'll talk about this in a moment, that oftentimes they may experience what we call invalidation from the environment. And that invalidating environment doesn't intend to be mean. It's just that the environment doesn't get the experience of the individual who's highly emotionally sensitive and who experiences this vulnerability to emotion dysregulation. Mm. Mm.
Yeah, I see that a lot, right? And then you're absolutely right. The invalidating environment is really easy. It's really easy to for it to happen because, again, it seems like the person's response is so disproportionate to the situation. And when you see it on that graph, right, like it's not just that situation, it's been this build because they haven't been able to get themselves to a baseline at any point. So it's just this building of emotional reactivity. And so then when this thing happens, it's like the straw that broke the camel's back, like every time, even though it's. And so then when somebody who maybe has a better ability to return to baseline is interacting with somebody, of course, it makes sense that an invalidating environment would come about, because it's like, this is not a big deal. We can handle this. Why are you,
mm-hmm.
right?
That's exactly it, right? Like the invalidating environment is trying to problem solve and has the capacity to problem solve much differently than the person who struggles with emotion dysregulation.
Right. And then there's these other layers too, right? Around the fear of abandonment and all of these other things, that when somebody who has that problem solving ability is trying to put those things forth in that space, it can also exacerbate it for the person with borderline, because then all of a sudden maybe they might trigger those fears of abandonment, or feel like this person is trying to distance themselves from them because they're saying or doing X, Y, or Z in that moment too.
Mm-hmm. Right. And internally, for a lot of people I work with who've been diagnosed with BPD, there's a really intense shame response. Yeah. Like, why can't I, like, upon hearing somebody say, like, what's wrong with you? Why can't you problem solve this way? Right. Like, I work with a lot of parents who are like, why can't you just get your homework done?
Right.
Why can't you just sign up for class? Like, I had this one teen who this past week did not make it to school online. Mm-hmm. And she's, in a remedial program. So she doesn't have like 4 classes, like a lot of her age peers. And for her, like, signing on to Zoom was not what I think of it. Mm-hmm. Right? Like, usually it's just like, I click on, I put in the meeting code, and then boom, I'm on. But it was like, she had to get out of bed. She had to go to the computer. She had to turn it on. She had to find the Zoom code. She had to do all of these things. And for her, it just felt like one step after another was just really, really difficult. Yeah. So task difficulty is oftentimes something that we can validate for a lot of our clients who have this difficulty with emotion regulation, that what others perceive to be easy for them is really hard. So that's that bit about emotional dysregulation. And you can see how if somebody's struggling with emotional dysregulation, it leads to interpersonal dysregulation, right? Like the chaotic environments, fear of abandonment, difficulty being able to express what it is that they need. And this ties in with that self-dysregulation because in order to have effective relationships, you have to be able to, one, express spontaneously and effectively what is going on internally for you in an emotional way. And so if many of our clients aren't able to do that, of course it's going to affect their relationships. And consequently, the unpredictability of their emotional dysregulation erodes that sense of self. If you don't know how you're going to be coping with your experience of your emotions from one moment to the next, there's going to be a ton of avoidance that is done as a means of coping, because then it's like, well, I don't know how I'm going to be, so I'm just going to like not go to school anymore, or I'm going to like not go to all these social things because I don't know if I'm going to be able to tolerate it or not.
Right. Mm.
And then there's the behavioral dysregulation that I talked about, which comes out of the emotional dysregulation, that the behavioral dysregulation is oftentimes a means of trying to regulate one's emotions, to calm oneself down. And I'll hear this from a lot of my clients who engage in self-harming behaviors, that it validates the emotion. It may be something that is soothing because your body's like dumping a ton of endorphins in because it's like, it's injured. Mm. Or it may be that there's some reinforcement from the environment, like people are going to respond in some way, shape, or form. Yeah. And then the last thing, that cognitive dysregulation, that it's not just dissociation and paranoid ideation. It can show up as like really, really black and white thinking, or self-judgment, or judgment of others. Mm. So from a DBT perspective, borderline personality disorder is a systemic emotion regulation disorder. Okay, all the behaviors that we just talked about have this function of regulating emotions, or are a natural consequence of emotion dysregulation. They come out of the emotional dysregulation, which makes sense. People are going to distance themselves from somebody who is expressing really intense emotions frequently. So in this biosocial theory, there's this transaction, right? That's what we mean with all these arrows. But there's this transaction between the person who has this biological dysregulation in the emotion regulation system and the invalidating environment. So the idea here is that if you take somebody who's just, highly emotionally sensitive, and you put them in a slightly invalidating environment over the course of time, there's going to be these dances that lead to really problematic behaviors and this experience of being constantly emotionally dysregulated. Right. So what I love about this model is that it takes blame away from my client, and it takes blame away from their parents. Mm. Okay, I'm not blaming either side. I'm not saying you're wrong and you're wrong. Like, I'm working with these parents in my parent group on Thursday, and one parent was just really struggling with the idea of like radical acceptance and what it means to just acknowledge like this is what's going on with his teen. And he was just saying like, I just want her to learn how to work hard. Mm. Like, I don't understand why she's being so lazy. And he's using all these pejorative terms. And I just said, look, the thing that I just want to throw out there to you is that, one, your teen's not doing this on purpose to make your life miserable. Your teen is feeling really miserable. Mm. And the things that she's doing are an attempt to not feel quite as miserable. Mm. So when she's leaving at night, I don't think she's saying like, F you. I think when she leaves at night, she's trying to find something that distracts her from like all the pain that's going on internally, right? Her shame, sadness, fear, like all this stuff that's going on. Yeah. So that's what I love about this biosocial model. It just helps us to understand there's this dance. Mm-hmm. So if we can help the environment to become more validating of what is valid, right? We don't want to validate that which is invalid, but we can help the environment to validate what is actually valid. Like that will change that dance. Like when we were talking about this with parents, a lot of them were recognizing like, you know, I just have to radically accept that my kid is going to be struggling with school. And so instead of pushing them to do the things that I think are going to work for them, like I need to come alongside them to help them to problem solve what is actually going to work for them.
Right. That's really good, because it's that both and of not just working with the client themselves, but working with those that are in their environment, right? To help them do this dance better. Because if the environment continues to be an invalidating environment, it's not that the individual with borderline with BPD can't learn how to navigate that, but it just makes it a lot more difficult, right? And if we can also target the environment itself to say, like, here's what's going on with the person that you love, here's how you can support them, here's how you can better be on the same page, right? Like if the parents are trying to do a waltz with their child and their child is over here doing the Dougie, like it's not going to work, right? Like we have to be doing the same dance. We have to be understanding how to create an environment that is validating rather than exacerbating the situation.
Exactly. So that's the biosocial model in a nutshell. Let's talk about treatment in a nutshell. So in order for standard DBT to be something that a clinic or an individual says that they offer, all of these things have to be available, right? So there's the individual therapy component, there's the outpatient, or there's the group skills training component. So individual therapy is where we drag out new behaviors. Skills training is where we cram in new behaviors, is what we say. The telephone consultation just refers to the opportunity for clients in crisis to call their clinicians for skills generalization, right? So if somebody's in crisis, they can call for skills coaching. It's not a replacement for therapy on the phone. It's usually 5 to 7 minutes. There's the therapist consultation team meeting, which is an opportunity for us to get the treatment that we need to build empathy, to have compassion, to be effective, to not reinforce problematic behaviors. And then there are also these uncontrolled ancillary treatments like pharmacotherapy. A lot of our clients are on medications to help with mood regulation. And periodically, it may be that if a client is not safe to themselves, that they may have like inpatient psychiatric treatment. So if any of these is missing, if somebody's like, well, I don't do telephone consultation, well, you're not doing standard DBT. If you don't have a consultation team meeting regularly, it's not standard DBT.
Right. Which I think is, again, an important note, because people will say that they do DBT when really all they're doing is skills training, right? They'll try to bring in some skills, and distress tolerant thoughts and ideas around the skills there, but that's maybe DBT informed treatment, but not full DBT therapy, because in order for it to be fully DBT, it needs to have all of these components. And so
exactly,
as particularly as emerging professionals, I think that our students need to hear that and know, right? Like it's not both for them, what they're practicing and what they're doing, but also when they're looking at referring people, if they're looking at places where they're working and things like that, that they're mindful of the language, that maybe they're using DBT skills and DBT informed approaches, but that really true DBT has to include all of these components. And again, what you've talked about and hearing the composite, how important it is in order for a DBT on the whole to be effective, to have each piece of this in place in order for it to be truly effective.
Absolutely. And let's take it a step further, right? Like it's not just about the clinician, it's about the client.
Right, absolutely.
Because many of our clients who've been diagnosed with BPD are told DBT is your last hope. So if they are participating in DBT treatment that isn't standard, but they believe that it is and it isn't working, it increases their hopelessness. So it increases their risk for engaging in life-threatening behaviors.
That's good.
Right. So if you're doing skills training, just say that you're doing skills training.
Right. Right. That's good.
That's fine. That's fine. It's informed consent.
Right. Right. Yep. Absolutely. And it's not false advertisement, right? Of saying, and again, just false advertisement, but particularly for the client who already is at risk of highly emotional dysregulation, right? To be thinking that they're getting the thing that they've been told is the best thing for them, but they're not getting the fullness of that. It puts them at high risk. It puts them at more risk of, like you said, self-harming behaviors and hopelessness. And so it's our job to be really mindful of our language, and when we're referring clients, that we're making sure that it is a true it's a true DBT model. It's a full program and not just skills informed.
Exactly. So these are the functions of DBT treatment. The first is enhanced capability for many of our clients. Like, a lot of them don't do the things that their environment may expect them to do because they may not know how to do it. Right? Like, watching somebody drive doesn't necessarily mean that it translates into your ability to drive. Right. So learning skills in regulating emotions, learning skills to be able to be effective in asking for what it is that you want or saying no. Improving motivational factors. So from a behavioral perspective, motivation is not an internal thing. Right. Motivation refers to outcomes that are powerful enough to get you to do something. Right. So this ties back to that life worth living goal, which we oftentimes use to increase motivation for many of our clients. Like, one of my clients who was struggling with getting on Zoom calls, she wants to be able to help people. And we talked about how, like, okay, if you want to help people, you gotta not be in bed. Right? You want to interact with people in more meaningful ways. Well, doing it from your phone in bed may not be optimal.
Right.
We want to help assure generalization to the natural environment. That's where the phone coaching comes in. That's where we do a ton of behavioral practice. And so that's actually been one of the benefits with Zoom treatment, is that I get to see people in their natural environments.
Yeah.
And so it's not just like, let's talk about how we're going to help you to clean up your living space. It's like, let's do this.
Let me see.
Let me take me with you. Like, let's go to this room. Like, I have a client who's in her 60s and she really struggles with behavioral activation. Like, she just moved into an apartment, like was furnishing it. Now there are like boxes everywhere and there's like stuff, and she's just, she doesn't know where to start. So I was thinking about her this weekend. I was like, okay, this is going to be our first 10 minutes of every session. We're going to set a timer for 10 minutes. We're going to do what I call the 10-minute task. Do something that you don't want to do. And it's a practice of opposite to emotion to action. We're going to do this together.
That's good. That's really good.
That's actually how I cleaned up my bookshelf.
I like that. I think I'm going to have to start adopting that as well myself.
It was in concert with a client because I didn't want them to feel like I was just watching.
Right.
I was like, all right, you and I are going to do this together. I'm going to clean up this space and you're going to clean up that space. I set the timer. We're like conversing while we're doing it. We're practicing like observing and describing, just making it a mindfulness practice. Timer goes off and we like show each other the work that we did. It was really cool.
That's awesome. That's really
cool. The fourth function is structuring the environment. So what is notable is that a lot of people I work with who have this biological difference in emotion regulation, because they find it really hard at times to engage in effective problem solving, they may engage the environment to do the problem solving for them. So we have what we call the consult to client model, whereby, you know, the client is the one who actually does the majority of the communication between providers. So instead of me talking to the group therapist, if there's a problem with group, then I'm going to coach the client to talk to their group therapist.
Right.
So The client learns skills to structure the environment so that the environment's not reinforcing maladaptive behaviors. The last thing is that it's an opportunity to enhance our capabilities and our motivation for treating people effectively. Like, it's really hard. I think I can't imagine being in private practice working with my clientele.
Yeah. No.
Because having a team where I can bounce ideas off, where I can do consultation, where I can get supervision, just makes it so much more rewarding.
And I would imagine just grounding too, right?
Oh yeah.
It can be really easy when you're in proximity to somebody whose kind of world is chaos to get wrapped up in that, or to take on some of that chaos. And so I think I would imagine that having regular access to group and to other people can also just be grounding of like, all right, this is not my chaos. this is not
sure.
And or the interaction that happened, validating like, all right, that wasn't me, right? Like that evaluation of me wasn't actually, that was this person's response, right? And being able to have that regular point of contact to ground yourself, I would imagine also extremely beneficial.
Oh, absolutely. Like, it's so great getting validation from other clinicians who know the treatment.
Right.
Like, oh my gosh, I can't imagine that, like, that happened, blah, 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 blah. Yeah. I have a couple of friends who are also DBT therapists, and we have our own, excuse me, informal consultation team where if something happens, we like text the group. We describe it very generally, and it's like, oh my gosh, blah, 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 blah. And it's like so great getting that validation. It's like, oh, thank you for seeing me.
Yes.
Okay, I can go on now.
Yeah.
So this is what we talked about earlier, that the primary goal in DBT is building a life worth living. So it's not just sufficient to reduce life-threatening behaviors. We simultaneously have to increase life worth living behaviors.
Mm-hmm.
So these are the stages of treatment. You can see at the top, it says pre-treatment. So until somebody starts group in standard DBT, they haven't really started treatment. So you can even have somebody who started group and they may not have a ton of commitment. So that's why we're constantly assessing for commitment, trying to increase commitment. And the thing is, commitment isn't just an opinion. Commitment is a behavior. Like when you say, I am going to do something, it's very different than I'll try, right? When you say I'm going to do this, or you make a commitment to not engage in a certain behavior, like it recruits thoughts and emotions very differently. So just as an example, my wife and I decided that after watching The Social Dilemma, we were going to, like, until after the election period, we were just not going to be on social media because I observed that it's been having an effect on my mental health. Like, I was feeling much more angry, sad, scared, frustrated, judgmental. Thoughts were much more judgmental. And since I've not been on for the last week, we started this last week, I just feel so much better, right? And the thing that's super helpful is, like, I notice that there are these moments where I experience like maybe boredom, or it's just habitual. I pick up my phone and then I go to that folder where I used to have Facebook and Instagram, but because we deleted them off our phones, I'm like, oh. And then I notice that there's this thought, like, you could just, log in. And then my wise mind kicks in and says, but you deactivated it. So remember why you're not on social media. And it's like, right, I could use this time to do other things. Like, I could read, I could check in with friends, I can send a text message, I can call my parents. Like, I can do all these other things instead of like just scrolling. And so that commitment recruits thoughts, emotions, and behaviors very differently.
Right. And again, there's that behavioral piece too, right? Like, it's not even just the saying, I am going to, not be on social media until the end of the elections, but it was also the deleting of the apps, right? Because one, getting into routine of this commitment that you've made, and two, but like actually creating barriers for you to not engage in that behavior.
Totally, right? Like it goes back to structuring the environment.
Exactly.
Right? Let me structure my environment to increase the likelihood of these desirable behaviors increasing in frequency, intensity, and duration.
Right. Yeah, that's good.
So when many of our clients come in, they're in pre-treatment, and then, you know, we get commitment to work on reducing behavioral discontrol, right? That's where the life-threatening behaviors come in, therapy interfering behaviors, quality of life interfering behaviors, and their goal is to get into behavioral control. And so when people are in, like, have reduced these life-threatening behaviors, what we notice is that they're still suffering emotionally. And that's where stage 2 comes in terms of being able to tolerate unpleasant emotions that may be associated with trauma or other really painful experiences. So in stage 3, this is oftentimes where people exit DBT therapy. You know, they're working on problems in living, experiencing ordinary happiness versus unhappiness, right? I had a client who once came in and she had really struggled with like a ton of anxiety and depression. And she came in session one day and just said, like, you know, I had this thing happen and I noticed that I just felt sad. I didn't feel like I wanted to kill myself. I didn't feel like the world was ending. I just felt sad. And I was like, oh my gosh, that's ordinary sadness. You know, we high-fived. This is pre-COVID. And it was just like, yes.
Yeah.
Like, you're doing it. You're tolerating these emotions that anybody else would have in that scenario.
Right. Right. Wow.
Cool. You know,
and that
and
it's good and okay to experience sadness.
Totally. And to not have it be devastating every time, right? Whereas in stage 2, people oftentimes, because of traumatic experiences, are just very emotionally avoidant, which then sensitizes them to any cues that may elicit those emotions. Yeah. And then stage 4, generally people are, you know, engaging in various spiritual practices. And that's oftentimes outside of DBT. So when we talk about primary targets, you'll see at the top it says dialectical synthesis. And what we mean by this is that, you know, we're not just reducing, actually, let me do a quick screen share. Getting the hang of this, Amber.
You totally got this.
Boom, bomb diggity. So what we mean by dialectical synthesis is this. That DBT is not, an abstinence protocol. However, we are asking our clients to, as much as possible, refrain from engaging in target behaviors. So the idea behind this is that, you know, we want them to consider that if they were to do this particular behavior, it would be a catastrophe. However, once they do it, we flip over to a harm reduction model where we acknowledge, like, it's not a catastrophe that you did this thing. Like, you can come back to being skillful as soon as possible.
Right.
So it's this balance between the two and this constant dance.
Right. And it is that, and I don't know if you've brought up that and language yet, right? But it's the both and, right? It's yes, abstinence, and it happens. So what do we do when it does happen? Or how do we engage in the harm reduction? It's that dance of the yes and, the both and.
Absolutely. Right. When it comes to target behaviors, as much as possible, this is where we want to live. And we recognize that if this were to happen, if it does happen, we just flip over this side until the person becomes skillful again, and then we make a commitment to being abstinent.
Right. Yeah. And I would imagine that given an individual who tends to have a little bit more black and white thinking, right? That's one of the challenges, is able to give themselves that cognitive regulation around that, because they've engaged in a non-preferred behavior does not then therefore mean that they are doomed, that life
Exactly.
or that they're never going to get back on track. It's the being able to say like, yes, this happened and I can still regulate and I can still commit
Totally.
and I can still find ways to reduce my distress in this moment and get back to this place.
Mm-hmm. Absolutely. Like if you think about it in the context of substance use, for example, when somebody is abstinent and then they violate it, they oftentimes enter into what we call the abstinence violation effect, where they get caught up in shame, right? So they experience shame, which is oftentimes only reduced, or they can escape shame by engaging in substance use behavior, which then when it wears off increases feelings of shame, and they just kind of get caught up in use. Right. So that's why the harm reduction model is the way out of the abstinence violation effect. So, we talked about pretreatment earlier. The function of, this is the beauty of DBT. Remember that like whack-a-mole idea, right? You come in and it's like the flavor of the week. Right. So we have a treatment hierarchy, and the priority is to reduce any life-threatening behaviors. That's self-harming behaviors, suicidal ideation, self-harming urges, even emotions that are tied to self-harm and suicide, like feelings of loneliness. I had a client who, when she felt lonely, hopeless, and worthless, that trifecta for her was what set up suicidal behavior and ideation every time. So we had to work really diligently on reducing the frequency, intensity, and duration of those emotions. Therapy interfering behaviors just refers to behaviors that get in the way of somebody being able to acquire skills and capabilities to have the life that they want to live. So if somebody is lying, if somebody is skipping therapy, if somebody is, not participating in group, if they're not doing their diary card, if they're not doing their homework, these are all therapy interfering behaviors that we target. And then quality of life interfering behaviors. This may be, depending on the intensity and the substance, it could be substance use. It could be some eating disordered behaviors. However, depending on how, like if it's restriction or, frequent binging and purging, that may actually bump it up to life-threatening behaviors. So this is where, we have to assess the function of the behaviors as well as the frequency, intensity, and duration to determine which category it falls into.
Right.
So the goal is to decrease all those and then increase these skillful behaviors that we're going to talk about: the mindfulness, distress tolerance, emotion reg, and interpersonal effectiveness.
Do you ever find that, if somebody is kind of the more life-threatening behaviors, if they don't manifest in a way that is typical life-threatening behaviors, or NSSI, can it be difficult to get them to acknowledge that that's what's happening here, even if it doesn't? So for instance, the person I'm thinking of, oftentimes the same kind of trifecta, or feeling that loneliness, feeling rejected, or feeling disrespected, all of a sudden will trigger a similar pattern, but it's other health crisis. I have to go to the hospital. I've been in an accident. I have a kidney stone. There's this unexplained thing. I have to go and I have to get tests done at the hospital. I have to go to the doctor. But it's a similar pattern. It doesn't come out in a quote unquote self-harming way, or a suicidal ideation or behaviors way, but a similar kind of physical manifestation. Is that something that you see? And two, if you see something that's kind of an atypical manifestation of self-harm, is that hard to get them to kind of engage here, in understanding what the pattern is? Am I making sense?
Yeah, I think for any behavior where this is where behavioral chains come in, which is kind of outside of the scope of this, this talk. Yeah. But it's a strategy to find out the function of any behavior.
Yeah.
Right. So I think prior to treatment, we have to assess what is the function of any behavior before we are able to categorize which level it fits into. And then once we understand the function, I think then we can speak with our clients about getting commitment to work on that behavior, because it may be problematic in terms of certain life worth living goals.
Right.
Right. Like I have a client who currently identifies as bisexual, has had like a lot of sex with men, which in and of itself, like for him, was problematic because he was married and it was not anything his wife knew about. So it became a dangerous behavior for him and for her.
Right. Right. Mm. Yeah, that makes sense.
Yeah.
Yeah.
Well, let's talk about dialectics. I think this is, we're coming close to the endish of this talk. So this is the central dialectic in DBT, meaning that we're constantly dancing between change and acceptance. So like I had talked about earlier at the beginning of the talk, that when Marsha Linehan was like focused on change, she got like a lot of pushback from her clients. Like, why do you want to change me? When she was focused on acceptance, like they felt like they were suffering.
Mm.
So that's why this dance is so important, because we have to be able to move our clients towards their life worth living goals. Simultaneously, we also have to accept them where they are in the moment.
Right. Mm.
So, and there are certain strategies that we use and skills that fall into change and some that fall into acceptance. Another dialectic is between our stylistic strategies, right? So we are like warm and reciprocal, like this is a practice of acceptance, it's a practice of validation. And sometimes we're just really irreverent. We're just saying what needs to be said.
Yeah.
Like the client I just mentioned, there was a period of time where he was self-harming and he was cutting himself on his upper thigh. And I just said to him, what? So you're self-harming? So what did I say? I said something like, oh, so you're coping like a teenage girl.
Mm.
And he was like, what? And he's like this manly man. And I was just like, yeah, I mean, you're self-harming on your upper thigh. I don't have like the largest group of individuals I work with who self-harm on their upper thigh are teenage girls.
Mm.
And he like did not self-harm for months after that. Right. So irreverence is not sarcasm.
Mm.
There has to be the foundation of a trusted relationship in order for irreverent strategies to work.
Right. Right. Mm.
So we talked about this earlier, that in terms of intervention, right? Like I totally get that for some of our clients, especially teens, there may be more environmental intervention.
Right.
And as much as possible, we try to do consultation with the client, even with teens. Like, how can I coach you to be skillful in talking with your parents about wanting more time on your phone instead of talking to your parents about getting you more time on your phone? And if I'm having trouble figuring out which side to go to, that's where I get consultation from my team to help me to look at the pros and cons of each of these. And ultimately, what is beneficial for the client in moving them towards their life worth living goal.
Right.
So the last slide, these are just the DBT skills, just in a nutshell. Mindfulness is the foundation for all the other skills. And each of these skills has a function. So mindfulness is to help us increase our awareness in the present moment so that we can be non-judgmental with ourselves and other people. The stress tolerance is used to not make the situation worse, so that if somebody is experiencing crisis and they don't know how to problem solve that situation, or they can't problem solve it immediately, how do they tolerate their emotions so that they don't act out of them and make things worse? By engaging in life-threatening behaviors or, other quality of life interfering behaviors. Emotion regulation is all about not removing emotion, but learning to tolerate the really painful emotions that we experience as just being human, so that we can continue to approach people, places, and things instead of avoiding them. And interpersonal effectiveness is all about being able to skillfully figure out, like, what is the priority in any given scenario? Is it my self-respect? Is it the relationship? Or is it a particular goal?
Right.
So I think that's it, Amber.
Great. That's fantastic. Thank you so much. So I had a couple thoughts and questions that came up.
Yeah.
One is, so once somebody is in DBT and is getting DBT treatment, are they typically, is this typically long term? Like, are they kind of committed to this treatment? You know, like I think about like analytic or dynamic, which is kind of like this lifelong thing. And DBT, which being interesting, working with one list population, but also having a lot of behavioral principles and underlying principles that tends to be a little bit more short term. So what does it look like? What is the duration of typical treatment for an individual?
Love this question. So with our teens, we ask for a commitment of 6 months minimum. And then, but it's not like for years, right? Like that's actually really rare to have clients that you're treating for years. So we ask for commitment for stage 1 treatment for the duration of a year, so that they go through, for adults, like they go through the 3 modules in distress tolerance, emotion reg, and interpersonal effectiveness twice.
Okay.
Because each cycle is 6 months. And so many of our clients have actually found it to be really beneficial to go through twice, because the first time it's like they're drinking water from a fire hydrant.
Right. Yeah, so much. Yeah.
It is so much to learn. And then the second time round, because, you know, they've been using these skills, they're able to apply it more effectively.
Refine it.
So generally treatment's about like a year, year and a half, 2 years, depending. And then we've got like some stage 2 groups, one that's focused on skills consultation and the other that's focused on interpersonal effectiveness.
And you mentioned some groups and therapy with like parents for that environmental. Is that something like for like your adults, for support groups or groups for caregiver or partners or individuals in their environment or life for adults?
Right. So we do that with teens. We have multifamily groups that we run. But for adults, we don't have any such program per se at Portland DBT Institute. We have friends and family where parents can learn about, or family members can learn about, like DBT. They can learn some skills in validation. So it's kind of like a weekend thing. We've been talking about maybe doing some groups for family members to learn the skills as well, because it would be better. Like general, like DBT skills are life skills, truly, right? They're life skills. And so it would be really beneficial for us to do that at some point in time.
Yeah, something to think about.
Totally.
Yeah. Yeah, and I think my other just questions from a practical standpoint for students is if they are interested in becoming, like, training and learning how to become a DBT therapist, are there resources or places, do you all do training at Portland DBT? Where would one start to become trained?
Right. That's such a great question. So we do have like 2-day trainings, which I think are helpful for people who are already in practice. So we have co-leaders in our groups now from various schools. I think there actually is somebody in one of the groups from George Fox, which is kind of interesting. I was like, wait, you're not in the PsyD program. How did you find out? Like, because we're trying to, we would love to have co-leaders in all the groups. And I think we have co-leaders in most of the groups. So my hope is, like, we've been doing a little bit of transition in terms of who's doing what. But what I'd love to do is I'll find out who is coordinating co-leaders, and then maybe I can email you, and then I can see if we have openings coming up for any students. So that would be a great way to get exposure to the skills training groups. The thing about individual is that I think to get training, like, you'd have to be working with somebody who is trained in DBT to get that piece of supervision in individual. It's really hard to learn that outside of a DBT clinic context.
Yeah. I want to, and even to have the exposure to the population too.
Right.
The access to the population to learn it. Yeah, that makes sense. Great. I had another thought and it just flew out my brain. Yeah, I can't think of what other. I'm sure it will come to me at some point. Workers, yeah. It'll come to me at some point, but I can text you and I can send it along to them if I think of something. And if students have questions, are you okay with them contacting you?
By all means, they can totally email me.
Excellent. I will share your email for those who have questions, and or I'll collect questions and kind of send them along. And
oh, like a digest? That would be great.
yeah, kind of collect some questions. We could do this again, or something to kind of ask the questions and get some answers for them too. So maybe that would be an option as well.
That would be cool. That would be awesome. I'd be totally up for that.
Sweet. I love it.
I mean, what else are we going to do this fall and winter in quarantine?
I mean, why not? Perfect. Well, thank you so much, Erica, Dr. Tan, for just giving of your time and your expertise. This is so helpful. It's helpful for me. It's a great refresher. I always learn every time that we talk, we get something out of it. And it's really great to just look through and talk through all the tenets of DBT again. And I know that this is going to be really, really helpful for our students too. So thank you so much. And
oh my gosh, thank you. Thank you for your flexibility. And I'm so glad that, we were able to figure something out.
Yeah, me too. I think that this is going to be fantastic for our students. So thank you so much.
You're welcome. Take care.
Bye.
Bye.